So when you have exhausted all your options, when a clubfoot which has been treated but did not respond to treatment and is resistant, when the deformity comes back, or in a child which has never had treatment, what do you do? Gradual correction with a frame is a useful skill set to have in this situation. I have borrowed the images for this talk from my bosses in these three centers where I've trained, from Rujuta Madam at Wadia, from Mr. Nayagam at Liverpool, and Mr. Fernandez at Sheffield. When to do a frame? It is definitely not the first line of treatment. When a child has had previous surgeries and there is scarring in the foot, any other further open surgery is going to scar it more, and that is when you think of a fixator. In older children who have rigid deformities, again, fixator is your friend. In club feet, the deformity is four-dimensional. There is a three-dimensional deformity in the bone and soft tissues, and this deformity worsens with time. In a child who is weight-bearing on a deformed foot, the osseous anatomy is ossifying while the forces are transmitting through the malaligned joints, and this is causing these abnormal forces to deform the bones further. In this situation, only an external fixator to stretch the soft tissues is not going to be enough, and you might need a combination of an osteotomy with an external fixator. Paver score can be used as a guide to assess and to help you what to do. It is a clinical score which assesses 5 parameters in the foot. These 5 parameters are scored based on the angle of deformity into 1, 2, 3. This factor is then multiplied depending on the age of the child, and the final score tells you whether you should cast the child or go ahead for some other form of treatment. With an external fixator, you are doing more than just stretching. You are inducing growth based on the principles of distraction, histogenesis. It's not an acute correction, so there's no imminent danger to the nerves and vessels while you're doing this gradual stretch, as long as you put in your wires through the safe zones. It gives you the advantage of making adjustments while doing the treatment and post-operatively to keep monitoring your correction. And you can have a more precise correction while doing it. In an osteotomy, in a closed wedge, the foot size will decrease, while in a fixator, you have the benefit of increasing the size of the foot. You can use the different principles of osteotomy in correction with a fixator if your cora and your angle of correction are at different points. The fixator is a stable construct which the child can weight bear in, and this helps reduce or prevent the osteopenia that can go with the long-term treatment in the child. Based on what you have in your toolbox and your skill set, there are 3 different types of fixators that can be used in clubfoot: a Jess fixator, a circular Elizaro fixator, or a TSF or a hexapod. These can be quite tricky and challenging, all 3 of them, and don't hesitate to phone a friend in these situations. The principle of Elizaro is tension stress effect, where a regulated controlled form of stress to the tissues causes them to be metabolically active and proliferate. This happens at the level of the connective tissue and the muscle and the bones. The frame can be an unconstrained structure or a constrained structure. When you do not use a hinge and you let the bony anatomy guide you, that is called as an unconstrained structure. And a constrained one is where you use the hinges to guide you to the direction of control and the position of correction. Any fixator will have 3 phases. You have the correction phase where you will do the turns, and that will correct the deformity. You have a static or a holding phase where you want the tissues to lose their memory and stay in that position. And then you have a maintenance phase, as has been explained by all our speakers, that the tissues do want to still go back. So you have to maintain them in a splint during daytime and nighttime. Any fixator will have a bony hold in 3 segments: in your tibia, in your hindfoot, in the calcaneum, and in your forefoot. And these segments will be connected to each other by your distracting rods or the motors. The tibial construct to the hindfoot to the forefoot, and the forefoot to the tibia. Jess is an unconstrained system which uses the soft tissues as a hinge to turn around and correct the foot. It relies on the normal anatomy of the child. So the earlier the deformity is to be treated by a fixator, Jess would be the preference in a younger child. These wires are not tensioned, they are only pre-stressed, meaning that they can be used in softer porotic bones, but the construct is not stable enough to weight bear. These frames are easier to apply since you don't have to think where to put the external hinge, but these frames often need to go back to theater every few weeks to adjust your rods while the correction is happening. This is an example from Vardia, a syndromic child, 3-year-old neglected clubfoot who had addressed treatment, and on the right is the correction post-removal of the frame. In a circular fixator, as I said, you can use it only for soft tissue distraction with maybe a percutaneous soft tissue release or alongside an osteotomy. Younger the child, the better result will be with only soft tissue. These feet have some mobility and you can use that to correct your deformity. While in older children with arthritis, with deformed bones who are older than 8 years of age, rigid feet are more likely to need an osteotomy along with the fixator. The frame looks quite complex, but if you break it down, the 3 segments, as I said before, there are 7 motors plus 1 motor that goes at the end of the correction. There are hinges which need to go alongside the joints, which will guide your correction. This frame needs to be distracted for the first 5 days so that the talus does not impinge or crush against the ankle. All the motors will need a differential distraction based on the severity of deformity, and it uses the principle of Ponseti, which is a simultaneous correction of all the deformities. The hinges are the crucial part of the circular fixator. The tibial frame connects to the heel frame with a hinge at the ankle, which forms the bimalleolar axis at the level of both malleoli. If you can see this hinge, the posterior motor, this is the crucial hinge which needs to sit at the level of the subtalar axis. Now this axis goes in a normal foot from the posterolateral to the anteromedial, so this hinge should coincide to that level of the joint. A differential correction will correct the varus and the equinus in the hind foot with these hinges. The hind foot now connects to the forefoot, and these are motors dropped down plantarwards on the medial and lateral side, and again a differential distraction to correct your cavus and adduction. The forefoot frame connects to the tibial frame, again with 2 rods with a T construct on the distal tibial ring. And these again with a differential distraction correct your forefoot equinus, the cavus, and the supination. The last and the most important motor, the 8th motor for derotation, is attached to this T extension, and the hinge for that sits at your talar head, and the motor is medial, which turns the forefoot around to reduce the alignment and externally rotates the calcaneum. You can use different colored markers for your distraction motors to guide the patients as to what they need to do when for which rod. Toe contractures can be prevented by using K-wires or toe slings in these patients through the treatment. And as described in the previous talks, tibialis anterior is often stronger in these children than the peronei. So a transfer, tibialis anterior transfer can be planned at the end of the correction. This is a case from Liverpool, which was a 7-year-old child with a circular fixator for correction and the cast in overcorrection at the end of the treatment. Do remember to hold the frame as well in slight overcorrection in the static phase. On the left is a case from Sheffield, 7 years follow-up. Again, a child who had previous soft tissue releases and relapsed, and the frame with a post-correction 7 years follow-up. On the right is a bilateral symmetric deformity, the right side being corrected and the left side now going for treatment with a circular fixator. The osteotomies are a separate talk in itself along with fixators, and there are complex osteotomies, a U-shaped osteotomy of the talus, a V-shaped osteotomy where there is a deformity in the hindfoot and the midfoot, and along with this osteotomy, then placing the appropriate hinges corrects the deformity gradually. The Sinai team, the Sinai group, has described a technique called as Ponseti, which uses Ponseti and the talar spatial frame for correction. It comprises of 2 rings, 6 struts, and they have said that it controls the rotation better. There are 2 types of frames that they have described. Type 1 is for a hind foot deformity with a mild component of forefoot deformity. And a type 2 frame is a severe foot with both hind foot and forefoot deformity. They have staged the correction into 2 stages. They advise to cast the foot for correcting the forefoot and then go on to TSF. In the type 1 frame, so after correcting the forefoot, the stage 1 corrects everything other than the hind foot. And in stage 2, they modify the frame and then go on to correct the hind foot. What stage 1 comprises of is an epiphyseal wire, which connects to the tibial ring to prevent separation at this physis, and an olive in the talus, which again connects to the tibial ring to prevent any motion, any correction at the ankle joint. And all your correction in stage 1 will happen at the subtalar joint. So you can see how the oblique frame becomes straight. And once that is done, the talar wire is disconnected from the tibial ring and connected to the foot ring. And then the equinus is corrected. As you can see, the angle is correcting here. And once that is done, they overcorrect the deformity by about 15 to 20 degrees. The type 2 frame is same as type 1, with the only difference that at the end of all of this correction, the forefoot ring is cut at 2 places, medially and laterally, and an Elizaro extension is applied. And then the forefoot cavus and adduction is corrected as Elizaro on this frame. This is an example from their paper where they have shown a pre-op and a post-op correction with Ponce-Taylor technique. As with any frame, there are complications, frame associated of pin site infection, pins losing out, cutting through, contractures in joints above and below, and infection in the bone. Specific to the clubfoot tame, you have to watch for a talar subluxation. While you're doing the distractions, watch for physeal separation. This can eventually lead to growth arrest, so you need to monitor the child for that. And toe contractures, which can be prevented by K-wires or toe slings. A lot of papers in literature, most of them have shown good results with frames. One paper from 2006, which has suggested that results were poor with the frame correction. TSF is a fairly recent method, and the literature describes only the technique and just one paper with short-term immediate results, which have been good. We are currently doing Ponce-Taylor in Manchester, and hopefully we'll have something a few years down the line. Fixators are tricky. Tread carefully when you go ahead with them. They can go either ways, so be cautious and don't hesitate to phone a friend if you are struggling.